Hi, my name is Louis and I'm a medical resident at the Royal Victoria Hospital, and this is the Introduction to Bedside Ultrasound online capsule. With this online session, I hope to stimulate interest into bedside ultrasound. I think we're all aware that it's an increasingly important skill to develop. The purpose of this capsule won't be to go over the scanning technique, but rather we'll focus on reviewing the anatomy and we'll go over some of the key abnormal findings that you may encounter when practicing bedside ultrasound. There's a number of reasons why bedside ultrasound has been gaining in popularity over the last 10 years. It's inexpensive, it's fast, it's safe to our patients, doesn't involve any ionizing radiation, and more, it's readily available at the bedside. As I hope to show you in the next slide, it has a broad range of applications in internal medicine. In many cases, it can help us expedite our workup and even guide initial therapy for our patients. Bedside ultrasound can also help us improve our knowledge of anatomy and physiology, especially of the cardiovascular system. And finally, in a time where the constraints of modern medical practice pull us further and further away from patients, bedside ultrasound is just a nice opportunity to spend time with patients and build rapport. This slide illustrates some of the key applications of bedside ultrasound in the field of internal medicine. As you can see, beyond the traditional applications of lung, cardiac, and IVC ultrasound, there's a number of situations where it could be useful to put the probe on to clarify what's going on with the patient. So next time you encounter a diagnostic dilemma, ask yourself, could ultrasound be helpful in this case? In many situations, the answer will be yes. Before we begin, I just want to touch on a few caveats to keep in mind when using bedside ultrasound. First, as with any ultrasound study, the accuracy will depend on the experience of the operator who's obtaining and interpreting the images. So I think we should be humble as we're all beginners learning this new technology, and we should be wary of overconfidence when reporting our findings. Ultrasound doesn't replace a good physical exam, it doesn't replace clinical judgment. It's simply an additional data point that has to be put back into the overall clinical context to be useful. Finally, if a positive or negative finding is going to affect your management, I think it's good practice to order a follow-up study to confirm your findings. And correlating your findings with a formal study is really the best way to learn ultrasound and to refine your skills. This online capsule will be divided into 5 sections. First of all, we're going to go over some basic principles and tips to get good images. Then we'll sequentially go over evaluation of the lungs, the heart, and fluid responsiveness, which will focus on IVC. And finally, we'll put it all together as part of the RUSH protocol, which is a systematic approach to evaluating a patient in shock with bedside ultrasound. So first, just some practicalities. Ultrasound machines are notoriously dirty, and as they travel from patient room to patient room, they pick up a bunch of nosocomial organisms. So here's a few things that we could do to reduce the possibility of transmitting infection via the ultrasound machine. First of all, the ultrasound probe, the probe holder, and the keyboard should be disinfected before and after use. Never trust the person before you for having left the machine in a clean state. The Sanding Cloth Plus wipes, which are found in the red top containers, are appropriate to use on our machines, but be aware that any bleach-containing wipes can damage the probe, so please don't use any bleach-containing wipes when cleaning the machine. Ultrasound gel bottles that are shared from patient to patient have been associated in a number of studies with nosocomial pathogen transmission. So I think it's really best practice to use disposable gel sachets for every patient. And the muco-lubricating jelly sachets are perfect for this purpose. They're essentially the same as ultrasound gel and they're readily available on the wards. For sterile procedures, full ultrasound probe covers and sterile gel sachets are available. And for aseptic procedures, this could be a peripheral IV insertion, for example. Even though you're not setting up a full sterile field, an impermeable cover should be placed on the probe to prevent contamination with blood and body fluids. And a sterile 4x4 tegaderm is appropriate for this purpose. Anytime a procedure is being performed, appropriate gloves should be used, but I would personally recommend using gloves every time you do ultrasound, even when you're not doing a procedure, just to prevent some of that sticky ultrasound gel from getting onto your hands. Since bedside ultrasound has only recently become mainstream, there's little guidance on how to chart our findings, but I think a good rule of thumb is to focus on qualitative findings and to avoid charting quantitative measurements unless you're very confident about the findings. So for example, it might be appropriate to say decreased EF, but to put a numerical value on the ejection fraction, that's something that requires several months, if not years of training, and would not be appropriate at our level. Another thing to keep in mind is to express one's level of certainty in the findings and any technical limitations. So if you're unsure what you saw or if the views were difficult, don't hesitate to chart it. The radiologists and the echocardiographers do it all the time. So here's a few tips to get good images with bedside ultrasound. This is the very basics. First of all, proper patient and examiner positioning is key. So typically bedside ultrasound exams are done from the right side of the bed. Take the time to adjust the bed to your height so you're comfortable when scanning. In some cases, especially with cardiac echo, changes in patient positioning can be helpful as well to improve views, and we'll go over that a little bit later. Using enough gel is always a key to success, so please be generous. And depending on the probe you use and the structure you're scanning, you can use different grip positions, but in general, you want to apply gentle but firm pressure in order to maximize that contact between the probe and the skin to get the best images. A tip that's helpful for people who are beginning is to deliberately slow down their movements. So use slow sliding movements to find the initial image, and as soon as part of the structure you want to see is in view, just use a very gentle angulation motion to refine the image to perfection. So this is the machine we have on the wards at the Rural Victoria, the Zonare Z1 Ultra, and over the next few slides I want to highlight a few key elements required for you to set up with the machine. So the first step is to select the transducer, and you can do that by pressing the transducer button at the top right of the machine's keyboard as shown here. When you press the transducer button, three options are going to light up on the numerical display at the top of the keyboard, and the options are P, that's for phased array, L, that's for linear array, or C for curvilinear array. So the phased array probe, the P probe, is good for looking at the heart and the IVC. It's also sometimes called the cardiac probe. The linear probe is good for everything that lies close to the skin, so vessels, lymph nodes, pleura, joints, etc. And finally, the curvilinear probe is good for looking at deep organs, especially in the abdomen, and sometimes called the abdominal probe. Once you've chosen which probe you will use, just press the knob below the corresponding letter on the numerical display. Once the probe has been selected, various presets will light up at the top left of the keyboard. You'll see that the names are pretty self-descriptive. Just make sure that you select the appropriate preset by pressing the button below the corresponding preset on the numerical display. Once this is done, you should be ready for scanning, and the depth button at the right of the keyboard can be used, it slides up and down, can be used to adjust the depth of your image. Sometimes the image will be too bright or too dark, so you can adjust the brightness of the image using the knob with a B on it. B is for brightness. The brightness button is also sometimes called the gain button on different machines. Once you're satisfied with your image, if you want to perform distance measurements, you can use the freeze button at the middle of the keyboard and then select the measure button, which is marked with a little ruler. And then you can use the set buttons to mark the location of your measurements. So now that we know how to perform measurements on our machine, let's see how we can apply this knowledge to evaluate the lungs with ultrasound. The lung is not traditionally one of the organs we think of when we hear the word ultrasound. Air reflects ultrasound waves and has actually been called the enemy of ultrasound. So how can we apply ultrasound to an air-filled structure? It turns out that many disease states, pulmonary edema, pneumonia, pleural effusion, involve accumulation of water inside the various structures of the lung. And the accumulation of water in these diseases leads to abnormal changes on ultrasound images, sometimes called artifacts, that can give us some valuable information on what's going on inside the lungs. There's a number of different protocols for scanning the lungs with ultrasound. So one of the protocols is shown here. It's drawn from the blue study, which we'll review in a few slides. In the blue protocol, the lungs are divided into three zones, which are separated by the anterior and the posterior axillary lines. So what's important to know is that specific pathologies are more likely to be found in certain zones. In a supine patient, air flows to the top, so signs of a pneumothorax will be best seen on the anterior chest in zone 1. Water flows to the bottom, so pleural effusions obviously are more likely to be seen in the posterior chest in zone 3. And diffuse or patchy processes like edema or pneumonia can potentially be seen in all three zones. In order to scan the lungs, the exam begins with the probe indicator to the patient's head, with the probe oriented perpendicular to the patient's ribs. You could use a linear or a curvilinear probe for this exam. The curvilinear probe is more helpful in delineating deeper structures, and the linear probe provides better resolution to look at superficial structures like the pleura. Once the probe's in position, just use vertical sliding movements to find an interspace between two ribs, and here's the image that you will get. So this slide illustrates the normal anatomy of the lung with the probe straddling an intercostal space. Note that the probe depth here is set to 10 centimeters, which is a good starting depth to get a general overview of what's going on in the lungs. You can see that there are two black shadows which indicate the ribs and the space between them, which is the intercostal space. The shiny white line in the interspace is the pleural line, which actually consists of a visceral and a parietal pleura opposed to one another. And everything above the pleural line is the subcutaneous tissue overlying the intercostal space. In addition to the anatomical structures that we showed in the last slide, I want to highlight here a finding called A-lines. So these A-lines are repetitive horizontal artifacts that course in parallel to and below the pleural line. They're not an actual anatomical structure. They're just an artifact of the ultrasound image. But the presence of this artifact is useful because it tells us that there's air under the probe. So the way to remember this is A for air under the probe. You would expect to see A-lines, for example, in a normal, well-aerated lung as well as in a pneumothorax, but you would not expect to see them in consolidations. This image shows a similar view of the lungs in a patient with pulmonary edema. So note here the appearance of these comet tail-like structures that arise from the pleural line and spread downward without fading. And like A-lines, they don't correspond to an actual anatomical structure, they're just artifacts of the ultrasound image. In general, B-lines tell us that there's extravascular lung water under the probe. So B is for water, either in the interstitium or in the alveoli. And this can be seen in pulmonary edema, pneumonia, pneumonitis, fibrosis, lymphangitic carcinomatosis, etc. A few B-lines here and there may be found in normal patients, but if you have two or more regions with two or more B-lines, that's considered significant. And if you see B-lines everywhere, especially if you see 3 and more B-lines diffusely, that indicates a diffuse increase in extravascular lung water. Statistically, this is highly likely to represent pulmonary edema, but again, consider that other diffuse interstitial processes like ILD or lymphangitic carcinomatosis can cause this type of picture. So this video shows a similar picture of a rib interspace, this time with a linear probe and a more shallow depth of view. Again, you can see the rib shadows and the pleural line in between the ribs. As the patient breathes in and out, you can see that the pleural line has a shimmering appearance. This is called lung sliding, and it indicates that the parietal and the visceral pleura are opposed to one another. So clinically, this means that there is no pneumothorax. The presence of lung sliding is highly sensitive in ruling out a pneumothorax. However, keep in mind that the absence of lung sliding doesn't necessarily rule in a pneumothorax. So we move on to a first clinical case. A nurse calls you to see a 60-year-old patient who was recently transferred to the ICU post-cardiac arrest. Patient's intubated, but he's in respiratory distress, hypotensive, tachycardic, significant hypoxemia. And on clinical exam, the patient has good air entry bilaterally. There's no jugular venous distension. The heart sounds are normal. And so what's the next step in treating this patient, and can ultrasound help? So these videos illustrate the results of lung ultrasound in this intubated patients. As you can see on the left side, the pleural line shimmers with respiration. On the right side, the line doesn't shimmer at all. On both sides, we see A lines, but no B lines. So as you can see, the difference here is subtle. Let me just play that again. Note that there's some motion on the right due to probe movement, but the key point here is that the motion is not timed with respiration, and so this doesn't represent lung sliding. There are two possibilities to explain the findings in this patient's right lung. The A lines are telling us that there's air under the probe. Absence of lung sliding in this context could mean that there's air between the pleura, a pneumothorax, or that the right lung is not ventilated, for example, if the patient has a right mainstem intubation. So remember that lung sliding is produced by the inflation and deflation of the lung, so a non-ventilated lung cannot have lung sliding. There's one additional sign that can help us distinguish both possibilities, and this is called the lung point sign. The lung point is seen at the interface between the region of the lung where the pleura are opposed and the region of the lung where the pleura are separated by air. So as a consequence, there will be lung sliding on one side and no lung sliding on the other side. Coming back to the patient in our vignette, this sign would be highly suggestive of a pneumothorax in an intubated patient rather than a right mainstem intubation, for example. Moving on to our second clinical case. So this is a 93-year-old female who has a significant smoking history, COPD, CHF, reduced EF. She presents with cough, chest pain, and shortness of breath. And she's hypotensive, she is tachypneic, and has severe hypoxemia on non-rebreather mask. Her chest x-ray is shown on the left. So what's causing this patient's hypoxemia? Is it a CHF exacerbation? Is it a COPD exacerbation? Does this patient need antibiotics for pneumonia? Let's see what the bedside ultrasound shows. So the lung ultrasound on the right here shows a well-aerated lung with perhaps one B line, and the lung ultrasound on the left, by contrast, shows absent A lines, an irregular pleural line, and an abnormal appearance of the parenchyma beneath the pleural line. This is called hepatization. So again, hepatization is a change in the appearance of the lung parenchyma whereby the lung acquires an echotexture that's similar to that of the liver. And this indicates consolidation and is highly specific for the presence of consolidation on a CT scan. So the BLUE protocol is a systematic way of assessing patients with acute hypoxemic respiratory failure, and it sort of puts all the signs that we've seen so far together. This protocol is based on an observational study of 260 patients. Patients with multiple pathologies were excluded, so those are all patients with a single main diagnosis. And this BLUE protocol identified the correct diagnosis, the correct cause for the respiratory failure in 90% of patients without additional testing. So the first step in the BLUE protocol is to check for anterior lung sliding. If anterior lung sliding is present, pneumothorax is considered to be ruled out. Moving down the algorithm, if the lung sliding is present, bilateral B lines suggest pulmonary edema. Unilateral B lines suggest pneumonia. This was called an AB profile, A lines on one side, B lines on the other side. Similarly, consolidation or hepatization suggests pneumonia. This was called the C profile for consolidation. Patients who have lung sliding who have anterior A lines on both sides indicating well-aerated lung anteriorly were further assessed with lower extremity Dopplers, and if a clot was found, the cause of the respiratory failure was presumed to be pulmonary embolism. If there was no clot, then the posterior lung zones were examined with the ultrasound for consolidation and effusion. Patients with posterior consolidation or effusion were considered to have pneumonia, and the rest of the patients were considered to have COPD or asthma exacerbation. Finally, patients with absent lung sliding and a lung point sign were considered to have a pneumothorax. And if lung sliding was not present but a lung point could not be seen, then additional investigations were considered to be required. So in summary, the BLUE protocol offers a systematic approach to patients with hypoxemic respiratory failure using bedside ultrasound. A lines, B lines, lung sliding, lung point, and hepatization are the key ultrasound signs that can help us better triage patients with respiratory symptoms using bedside ultrasound. And this concludes our section on lung ultrasound.